When we talk about the human inflammatory bowel diseases, we use these words to describe two distinct but related and overlapping conditions known as Crohn's disease and ulcerative colitis. Crohn's disease and ulcerative colitis are chronic, which means lifelong, inflammatory conditions of the gastrointestinal tract. We use medications that suppress the immune system to treat people with inflammatory bowel disease, but surgery is often required when medications fail or complications develop.
I can tell you a story of a patient of mine. He's a very busy lawyer, but already at the time of university, he underwent the first surgery. And this was okay. The first time, you can accept that surgery is part of the disease. But then, of course, when you know that the disease will come back, you start with medications. At that time, it was azathioprine only. And this was not an effective drug, and we know that it has a lot of limitations. And in fact, the patient relapsed again for the second time. We knew that the disease was advancing. At that time, there were not anti-TNF available, so we were forced to use steroids. But of course, neither azathioprine nor steroids changed the natural course of the disease, and the patient got a second surgery. And then same story, because those were the drugs available. But anti-TNF arrived. So we were able to have really the patient very well. 2 years of his life were perfect. He gained 15 kilos. He was really very active, very happy. But then he lost response to anti-TNF. Okay, we start with a second anti-TNF. We had it available. Minimal response. The disease progressed. And he got another surgery, and the drugs were finished because he was not responding to the anti-TNF. Now he's in a clinical trial. I know that the disease is advancing. We hope that the drug is going to be effective, but we will see what is going to happen.
The symptoms that are common between ulcerative colitis and Crohn's disease are diarrhea and abdominal pain. And when I say diarrhea, I don't mean a loose bowel movement here or there. We have patients come in on a weekly basis who are having anywhere from 10 to 20 bowel movements daily. They're waking up at night to move their bowels. They often have blood in their bowel movements as a consequence of inflammation in the gastrointestinal tract. This is a serious debility and contributes to horrible quality of life. Okay, and you've been good about taking all your medications? Because of the inflammation, there's what we call systemic manifestations of inflammatory bowel disease. So the inflammation not only affects the gut, but spills over throughout the whole body. So patients may develop fevers, they lose weight. The body is working so hard to perpetuate this harmful inflammation that it's not assimilating enough nutrients. Patients develop inflammation of the joints. We see arthritis, we see skin inflammation, we see eye inflammation, and up to a quarter of our patients with inflammatory bowel disease as well, as the inflammatory state literally spills out of the gut and affects other parts of the body.
For all the years that I was diagnosed with Crohn's, I knew that surgery was a possibility. And the entire time, I would say, I will do absolutely anything besides have surgery. Even the first time I went to see this doctor, I told him that it was off the table for me and I didn't even want to consider it. I started having initial symptoms when I was around 10 or 11. It started just with some bloody diarrhea, and we went to see the doctor, and he recommended changing my diet, and we did that, and the symptoms really went away for a couple of years. Then when I was in 7th grade is when we started having a few more symptoms come back.
Diagnosis for Crohn's disease can be very challenging because the disease can have a lot of overlaps with irritable bowel syndrome, with, for instance, anorexia. There are many young patients, girls, that are referred to us because they are not eating, they are losing weight, they are vomiting, and they receive this etiquette to be anorexic, but then at the end it turns out that they have Crohn's disease. They are not eating because when they eat they have bowel pain, and they are vomiting because they have an obstruction. And then it's too late because they've received this etiquette for years, and then the disease has progressed and they will undergo surgery from the beginning.
In 1999, I started having the symptoms reoccurring from Crohn's. Originally, it started as a lot of fatigue, just feeling tired. I also started having bloody diarrhea. That was, the first tip that something was really wrong. I remember staying home from school, just not feeling well and never being able to make it back. I quickly lost a lot of weight. I was already a small kid at the time, but I lost 25 pounds in a matter of a couple weeks. And that's when we decided it was time to make a change. We went to see the doctor. He almost immediately diagnosed me with Crohn's and admitted me to the hospital.
One of the tragedies in inflammatory bowel disease is that patients often are ill and suffering for a long time before a diagnosis is made. So part of our educational mission is letting the primary care physicians out there and even the community gastroenterologists know what the signs and symptoms of inflammatory bowel disease are. Because in order to diagnose inflammatory bowel disease, we're reliant on objective measures of inflammation and characterizing the type of inflammation in the gut. And I think the standard tests we use to make a firm diagnosis of inflammatory bowel disease are endoscopy and imaging.
Those first few days in the hospital when I was 13 are a bit of a blur. I just remember being very sick and wondering when I would ever be able to even get out of the hospital. I was bedridden for at least the first several weeks while I was there. I was being fed food through an IV because I wasn't getting enough nutrients because my body wasn't absorbing what I was eating. They had me on a very bland diet just to try to get any food into me, even though most of it was coming in through the IV. They also put me on a high dose of steroids to try to deal with the inflammation and get that eliminated from my body.
My journey with Crohn's started officially in 2006. And the reason I am so certain of when it started and how it started is because it coincides exactly with the time that I left South Africa for starting my new life abroad, first in the US and later also in the Netherlands. The first clear signals that I had problems were in January 2006 when I started passing blood. And I waited, of course, a few weeks before finally saying something, because, maybe it's just temporary or perhaps just something I ate or did not know exactly how to deal with it. Of course, in hindsight, things like this are clear alarms. But when you are healthy, or when you think you are healthy, you don't ring to the gastroenterologist right away. You sort of wait and see. I scheduled in a colonoscopy, and they had a look and they said this was ulcerative colitis because they only saw inflamed tissue in the last part of the large intestine.
Ulcerative colitis is a disease that affects exclusively the large intestine or the colon. Crohn's disease, on the other hand, can affect any region of the intestine. We say this is a disease that can affect anywhere from your mouth to the very end of your intestine, which is your anus. The most common area that we see Crohn's disease affecting is the large intestine, same as ulcerative colitis, but also the end of the small intestine, which is called the ileum. However, there's tremendous overlap between ulcerative colitis and Crohn's disease, and despite these clinical definition, there's about 10% of people we don't know which one of them they have. So this speaks for the need for better diagnostics.
I knew I had a visit to South Africa that was planned for July, my father's 50th birthday. And so I resolved to also see a specialist in South Africa, where maybe it would be easier for me to understand what are the consequences of what I'm hearing. During that time, however, things had gotten a lot worse for me. I did not only have stomach pain and bloody stools. The other big thing that happened was that I started having serious mouth ulcers, sores on the inside of my mouth that made it very difficult for me to eat. So I got home to South Africa, and by that time my mom had pre-booked for me a visit at the gastroenterologist, the specialist at the local hospital. And when I started preparing for the colonoscopy on Sunday afternoon, my body basically just gave in. I was immediately taken into hospital and also lost consciousness. There way too low blood pressure. I had lost a lot of blood, I had not eaten, and clearly dehydrated somehow. That was the beginning of me and my family realizing that this was more serious than we thought.
There are some symptoms that are unique to Crohn's disease. Patients with Crohn's disease, because it affects the small bowel, which has a much smaller caliber than the large bowel, when they get inflammation in the small bowel, this progresses to scar tissue and actually creates blockages. What happens from the scar tissue, the lumen of the intestine gets narrowed so food and liquids can't adequately pass through. And this results in pain, nausea and vomiting, and is a very serious complication that often requires hospitalization and definitely requires surgery to manage this, because all of the medications that we have in the world are not going to open up a scar tissue. This requires our surgical colleagues. And then usually after a surgery like this, we may use medications to try to prevent this from happening again. There is no known cure, and best we could do is control symptoms and try to keep the disease in remission with current medical therapy. So this is a problem that we're first seeing being diagnosed in the teens and 20s most frequently, and without a cure, this is something that people have to live with for their entire lives. In North America alone, there are probably 2 million people with Crohn's disease and ulcerative colitis. About half have Crohn's disease, about half have ulcerative colitis.
Before they were considered to be a rare disease. Now not anymore. These are the diseases of our future sons. They are spreading all around. There is a huge increase in the incidence, especially in the pediatric population. And there are no differences in terms of gender. They may affect males and females in the same ratio, so there is not a prevalence in one of the two genders, but there is a unique characteristics. These are the diseases that affect young people.
The year following that diagnosis was very difficult for me. All of my friends had sort of moved on with friendships at that point. It was like coming into a new school in the middle of the year, and I definitely had a difficult time adjusting to that. I can remember feeling very alone during that time and not feeling like I had any friends that I could turn to, because obviously nobody could understand what I was going through. And I was often too tired to be able to go spend time with my friends like I would have liked to, and ended up spending a lot of time alone that year.
What we often hear from our patients is that their friends and family say, well, you look well. The problem is they're wearing their badge of honor on the inside, and people can't see what's happening in here to really ravage their lives. And therefore, people assume that these are diseases that are caused by stress or caused by a poor diet or unhealthy lifestyles. And that's not the case. Just like rheumatoid arthritis, just like multiple sclerosis, these diseases are caused by an overactive immune system that attacks the intestine in people who have inherited the wrong genes from their parents. And that's a simple way of thinking about these diseases.
It was diagnosed as Crohn's right after the biopsies came in, after that colonoscopy in South Africa. Well, first I had an intense cortisone therapy. I was on high amounts of hydrocortisone on a drip IV in the hospital for about a week or a bit more. I missed my father's 50th birthday. I was in hospital. And the cortisone helped. Cortisone is a miracle. It has a lot of evil side effects, and I can talk for hours about my experiences with cortisone, but the number one thing that we have to register is that when you are that ill, the only thing that brings you back from a very far place is cortisone. Cortisone saved my life.
It's very frustrating for the gastroenterologist compared to rheumatologist to have only 2 drugs available, 2 biologics, 2 anti-TNF, while the rheumatologists have 8, 9 biologics. We use the drugs according to the disease severity. So if a patient is mild, generally we'll get only budesonide or steroids, and that's it. But then if the patient will relapse, then he will get a second course, probably with immunosuppressants. So we will add the azathioprine or the 6-mercaptopurine. And then if the patient will reflare, so the patient is becoming more moderate or severe, then he will get an anti-TNF. Nowadays, we are using anti-TNFs more and more because we are aware that especially in patients that are naive to immunosuppressants, so with early disease, the anti-TNFs alone or in combination with immunosuppressants are much more effective. And in the ideal world, probably we will give anti-TNF to everybody with lesions, with ulcers, or with biologic activities, such as, for instance, increased levels of C-reactive proteins. But in these days of economic restriction, we are a little bit limited, and so we cannot offer these drugs to everybody, as we were doing maybe a little bit more before.
I started in January or February the Remicade therapy at the hospital in the US. That was my second year in the United States, and I spent the whole year every 2 months going for Remicade at the hospital. Things went all right. I stayed on cortisone for most of the time, a tapering dose, but as soon as I got off the cortisone, symptoms would flare up. And so I would go back on higher cortisones again. But things changed when I moved, after being in the States for a year, back to South Africa for a temporary amount of time, and then coming to the Netherlands, to Europe, because I could not continue Remicade during the time. I could not continue Remicade in South Africa, and I could not immediately start Remicade in Europe without having seen specialists. So after about 5 or almost 6 months of hiatus between Remicade, I started with treatment, also biological, in Humira at the time, in Utrecht, with this team of specialists who were very dedicated to try and find out how this autoimmune disease is allowed to continue in my life so heavily. I did not seem to go into remission. It was almost 3 years that I've had the disease, and remission seemed to have eluded me all the time. So we started treatment, and during that time I just adjusted my lifestyle completely to this new life with Crohn's. I still was round as ever when my wedding pictures were taken in 2010. And even though I thought I had a relatively good quality of life, I often had periods of intense illness, hospitalization, and all the bad things that go with that.
I had good years during high school where I was mostly in remission. It was in 2004 when I went off to college that things flared up again, and this time did not go away. And I eventually was hospitalized that December for about 2 weeks. And I started a new medication, Remicade, that had not previously been available. I was on the Remicade for about 4 years. And around that time, I was having difficulty keeping my symptoms at bay. And so at that point, my doctor decided to take me off the Remicade and move me to a different type of medication. The first year or so that I was on Humira, it worked very well for me. It helped keep things quieter, and I was able to give myself a personal shot every single week, which would hold me over until the next week. But after about 2 years of being on the drug, it stopped being as helpful. I started having symptoms that were getting worse. I was still having a lot of inflammation in my intestines that my doctor would see through my colonoscopies. I also was still having issues with having to go to the bathroom a lot and very quickly. After the Humira wasn't working as well for me, my doctor decided to move me over to a new drug called Tysabri, but there are some severe possible side effects with that were a concern. So I started on that for about 4 months, and he did another colonoscopy at that point and realized that my symptoms weren't getting any better. And so because of the severe side effects, he decided to go ahead and pull me off that drug.
Despite our best efforts medically, sometimes surgery is a very important part of best treating inflammatory bowel disease.
One of the worst part of our job is really communicating to the patient that all the medical therapies that you have in your hands are gone, are finished, all your bullets have been shot, and the only last resource is to do an extensive surgery with a stoma. And this is very tough.
In my case, what I needed to have done was to have the complete removal of the colon and take what was left of the small intestine and form that into an ileostomy. Therefore, I would have to wear an ostomy bag that all of my waste would go into that and would be completely disconnected from the rest of the digestive tract.
So now the step is, let's try really to cross the first bridge is to undergo a very relevant surgery, and let's think about be safe and to be okay after the surgery. And then we will think about preventing relapse. And sometimes we also have the help of a psychologist. That is crucial.
My reaction when I heard that I would need to have an ostomy bag was denial, really, at the point. I just felt that I wasn't that ill, that I needed to have something like that done. And so I decided to stop all medication for the time while I tried to figure out what the next step would be, because for me, it just wasn't an option to have surgery.
This is often a difficult surgery for young people to accept, but I always reassure my patients who are going to need this type of surgery that their quality of life is going to be excellent. Once they have the surgery, what I often hear when they come back to me is they say, I wish I've done this sooner, because their lives are so much better.
In the weeks after I went off all medication, I realized how severe my Crohn's disease really was. A lot of the other medications were keeping some other symptoms at bay, and I started having a lot of joint pain. I started having some arthritis creep in, and ended up having a lot of pain to the point that I could hardly get up off the couch. My ankles swelled up to the size of baseballs, and I could hardly move around. And it was at that point that I realized that this was more severe than I had originally admitted, and I knew that surgery was going to be the best option. My husband was actually on board with the surgery before I was. After my doctor told me, first off, that he didn't have any options for me besides the surgery, my husband said, let's go ahead and do it, but I wasn't ready to accept that yet. And as I learned more about the surgery and realized that it was going to happen for me, he was very supportive. He told me that he would be with me every step of the way, and he has been a great strength to me through this and has really helped me get through and still feel like myself through the whole thing. After I made the decision to go through with the surgery, I still had several weeks before actually having it done. But it gave me the time to get to know the surgeon a little bit, to talk with him through the options, and also just to mentally prepare myself for going through this. So I'm thankful that I had the time to come to terms with the whole process before actually having to have it done.
In early February 2009, I had lost a lot of weight, more than 15% of my body weight over the last 3 weeks, and was immediately admitted to the hospital in Utrecht. They had done all the tests again, all over, to try and understand where exactly is the problem and how are we going to fix it. And then the only place where we ever found evidence, besides the mouth, was in the last 20 centimeters of the large intestine. I was told that in the hospital by my doctor that I would have to consider a stoma, that would make life a lot better for me. And I did consider it. I even went to the info session on how to keep it clean, how to maintain it, and to try and familiarize myself with the idea, which is a very foreign idea, of course, to anyone, and especially to a young girl who still wasn't married, and actually at that time, hoping to still have a natural, normal, sex life and having kids in a way that did not feel normal with the stoma. So to me, it was a very weird idea, but I was trying to be open to it because I was doing so bad health-wise that I was convinced that this was probably the answer. I guess I just always hoped that new medicine, there's always something being invented. Maybe if I just hang on 2 more years, somebody's gonna invent something that's gonna give me my life back, and I don't have to take this irreversible decision that I might regret if I had just stayed 1 more year or 2 more years running to the loo. And we delayed the decision, which I thought at the time was just a matter of time. I don't know if it's the right decision. It's definitely not the right decision if you're risking your life.
Hey, Keeks, how's it going up there?
All right, picking the salad.
Cleaning it out?
The biggest turn in events came right after my last hospitalization, which was January 2012. I had, again, a very high shot of cortisones to help with a serious inflammation. And I had so much cortisone that I remember 3 days, 4 days later, struggled to breathe because I had so much liquid on the lungs. Shortly after that, we had our first natural pregnancy. And, we were extremely happy, but it did not last very long, the pregnancy. And we had a successful 7-week appointment, which was the first, but at 9 weeks, things were not fine anymore. So we don't know exactly where things went wrong, but we were, of course, devastated.
But look at the tiny little thing. Look. Next.
But that's not really the end of it. The good news is it seems that at some point during 2012, I reached my first remission. Well, who knows what changed things, but things changed. And now that things have changed, now I know what remission feels like. Now I know what it's like to live without cortisone. Now I know what it's like to not plan visits around trips to the bathroom. My lower gut was, until recently, just so inflamed and so sick for so long that it seemed like, and it probably was at the time, the best decision to just bypass it. And by some miracle, we don't know yet why, I am better now with no stoma.
After my surgery in 2012, when I was recovering from that, I decided that I wanted a goal to accomplish. And prior to that, I hadn't been able to do much exercise or running just because I was so tired. And I also had the issue of trying to hold things in when I was running. So with having the ostomy, I decided I wanted to go for a triathlon. And so I started training for that, and I did my first mini triathlon in October of 2012. It was exactly 5 months to the day from my surgery. And that was a great accomplishment for me. And following the triathlon, I got involved with the Crohn's and Colitis Foundation's Team Challenge program, which is an endurance running program where you train with a group, raising money for Crohn's and colitis research and patient care, and training for a half marathon that you run together as a group.
I remember the first patient that I treated with a monoclonal antibody that blocked the inflammatory protein TNF. And I will never forget this patient because this is someone who had some of the worst Crohn's disease I ever saw. There's a complication in Crohn's disease known as a fistula, and what a fistula is a tunnel of inflammation that extends all the way through the bowel. And in this particular patient, who had many of these fistulas, they terminated on the skin surrounding his anus, so in his buttocks region. This unfortunate gentleman had 52 fistulas. We call this a watering can, because when you look at his backside, what you saw was 52 holes, and these holes drained infected fluid. This person came into clinic with a pillow because just the act of sitting down was extremely painful for him. And there was very little we could offer this patient outside of surgery, where we remove his entire large intestine. And even after surgeries like this, sometimes such bad fistulas don't heal. So this is a real problem. And we enrolled him in the study of a monoclonal antibody that blocks this inflammatory protein, TNF. And within 1 month, 51 of these 52 fistulas had completely closed. And I remember standing there with my mentor at the time, just shaking our heads in disbelief that we could see such a good response.